Let me ask you something, and I want you to really think about this before you answer. If your doctor handed you a prescription today, would you know whether that medication was actually safe for someone your age? Or would you just take it because you trusted it was fine? I've been practicing medicine for over 20 years, and I've focused my entire career on the health of older adults. And let me tell you, one of the most common problems I see walking through my door is seniors who are taking medications that were not designed with them in mind. Medications that work perfectly fine in a 35-year-old, but can cause serious, sometimes life-threatening problems in someone over 60. Today, I want to talk specifically about arthritis. Because if you're watching this, chances are you or someone you love is dealing with joint pain, stiffness, maybe some swelling, and you're looking for relief. That is completely understandable. But here is what I need you to hear. Some of the most commonly prescribed and over-the-counter medications for arthritis are actually on a list called the Beers Criteria. That's an official list maintained by the American Geriatric Society, and it flags medications that are potentially inappropriate for adults 65 and older. Today, I'm going to walk you through 5 types of medications on that list, medications that are commonly used for arthritis, and explain exactly why they can be so dangerous for you specifically. And at the end, I'll tell you what safer options actually exist. Now, I have to be very clear before we begin. Please do not stop taking any medication on your own after watching this video. Always speak with your doctor first. What I'm giving you today is knowledge, so you can have a better, more informed conversation with your healthcare provider. All right, let's get into it. The first category is NSAIDs, non-steroidal anti-inflammatory drugs. You know these. Ibuprofen, that's Advil, that's Motrin. Naproxen, sold as Aleve. Indomethacin, diclofenac. These are some of the most widely used medications in the entire country. And I get it. They work. They reduce inflammation, they cut down pain, and they do it relatively quickly. When your knees are aching and your hands are stiff every morning, you want something that works fast. NSAIDs deliver that. But here is the problem. Your body at 65 is not the same as your body at 45. And NSAIDs don't know that. Let's start with your stomach. NSAIDs block a chemical called prostaglandin, which, yes, causes inflammation. But prostaglandin also protects the lining of your stomach. When you block it, you're opening the door to ulcers and gastrointestinal bleeding. In younger adults, this is a manageable risk. In seniors, especially those also taking aspirin, a blood thinner, or a steroid, this risk becomes significantly more dangerous. We're talking about internal bleeding that can be life-threatening before you even feel symptoms. Now let's talk about your kidneys. As we age, kidney function naturally declines. It's not a disease, it's just biology. NSAIDs reduce blood flow to the kidneys. In someone with already reduced kidney function, this can push someone from managing fine to kidney failure faster than anyone expects. And then there's your heart. The FDA placed a black box warning, that's the strongest warning they can issue, on NSAIDs because of the increased risk of heart attack and stroke. This risk is even higher in older adults, and it increases with dose and duration of use. If you're also taking a common blood pressure medication, an ACE inhibitor, or a diuretic, NSAIDs can actually make those medications less effective. So you're not just risking your kidneys and your gut, you're undermining your blood pressure treatment at the same time. The American Geriatric Society, in their 2023 Beers Criteria update, explicitly lists oral NSAIDs as medications to avoid in older adults, especially for chronic use. That's not a small footnote. That is a formal medical recommendation from the leading organization in geriatric care. So what can you do instead? Topical NSAIDs, like Voltaren gel, can be applied directly to the joint. You get some of the anti-inflammatory effect locally with far less of the systemic risk. Acetaminophen at appropriate doses remains a reasonable option for many people. Physical therapy, aquatic exercise, and weight management can also reduce joint load significantly over time. The key takeaway here: if you are currently taking oral ibuprofen or naproxen daily for your arthritis, please bring that up with your doctor at your next visit. Ask specifically about the risks for your age and your other conditions. The second category is corticosteroids. Prednisone is the most common one you'll hear. Methylprednisolone, dexamethasone. These are powerful anti-inflammatory drugs, and for certain types of arthritis, like rheumatoid arthritis or lupus-related joint disease, they can be genuinely helpful in the short term. During a flare-up, a short course of prednisone can bring significant relief quickly. The problem, and this is a serious problem, is long-term use. Because when corticosteroids are taken for weeks, months, or years, they begin to cause damage that compounds with age in ways that are very difficult to reverse. First, your bones. Corticosteroids actively deplete bone density. They interfere with calcium absorption and slow bone formation. In someone who is already at risk for osteoporosis, which is extremely common in women over 60, this can accelerate bone loss dramatically. And what does that mean in practical terms? It means a higher risk of fractures. Hip fractures specifically are one of the leading causes of disability and death in older Americans. A medication that weakens your bones is not a small risk to accept. Second, blood sugar. Corticosteroids raise blood glucose levels. If you have diabetes or even pre-diabetes, long-term steroid use can make blood sugar extremely difficult to control. For some patients, it can trigger steroid-induced diabetes that didn't exist before. Third, your immune system. Corticosteroids suppress immune function. In a younger person, this is often manageable. In an older adult whose immune system is already less robust, this can mean more frequent infections, slower healing, and a higher risk of serious illness from infections that a healthier immune system would have handled easily. And that's not all. Long-term steroid use is also linked to weight gain, muscle weakness, which increases fall risk, cataracts, mood changes, and significant sleep disruption. The American College of Rheumatology, in their 2022 guidelines, is very clear. When corticosteroids must be used, the goal should always be the lowest effective dose for the shortest possible time. This is not about avoiding treatment, it's about managing it responsibly. Safer long-term alternatives for conditions like rheumatoid arthritis include a class of drugs called DMARDs, disease-modifying anti-rheumatic drugs, like low-dose methotrexate. Biologic medications have also transformed the treatment of inflammatory arthritis. And for localized joint pain, intra-articular injections, steroids injected directly into the joint, carry much lower systemic risk than oral pills. If you have been on oral prednisone for more than a few weeks for your arthritis, please talk to your doctor or ask for a referral to a rheumatologist. There may be options that manage your condition just as effectively with far fewer long-term consequences. Now I want to talk about something that has become increasingly common and increasingly concerning: opioid pain medications being prescribed for chronic arthritis pain. Oxycodone, hydrocodone, codeine, and one I want to specifically call out: tramadol. These medications are being prescribed more and more for older adults with osteoarthritis and other chronic joint conditions. And I understand why. When someone is in significant daily pain and other options haven't worked, it can seem like the compassionate choice. But the evidence is very clear. For chronic arthritis pain in older adults, opioids carry risks that almost always outweigh their benefits. Here's what worries me most: falls. Falls are the leading cause of injury-related death in Americans over 65. Every year, 1 in 4 Americans over 65 falls, and the consequences can be devastating: hip fractures, head injuries, loss of independence. Opioid medications cause dizziness, balance problems, and sedation. They make falls dramatically more likely. That's not a theoretical risk. That is a documented, measurable, serious danger. Beyond falls, opioids in older adults commonly cause severe constipation, which can lead to its own complications: urinary retention and confusion or delirium. Delirium in older adults can be a medical emergency, and it's frequently triggered or worsened by opioid medications. I want to take a moment to specifically mention tramadol, because many patients and even some physicians consider it a mild opioid. It is not mild. Tramadol is particularly dangerous for seniors. It lowers the seizure threshold, meaning it increases the risk of seizures, especially at higher doses or when combined with other medications. It can cause a dangerous drop in sodium levels in the blood, and it carries a risk of serotonin syndrome, particularly when combined with antidepressants, which many older adults are also taking. The CDC's 2022 Clinical Practice Guideline on Opioid Prescribing specifically recommends non-opioid therapies as the preferred first approach for chronic pain, including arthritis. And the 2023 Beers Criteria flags tramadol and other opioids as high-risk medications for older adults. So what are the alternatives? Duloxetine, brand name Cymbalta, is an antidepressant that has also been FDA approved for chronic musculoskeletal pain, and it has a much better safety profile for seniors than opioids. Physical therapy remains one of the most evidence-based treatments for osteoarthritis. TENS therapy, transcutaneous electrical nerve stimulation, can provide meaningful pain relief for some patients. And cognitive behavioral approaches to pain management have shown real, documented benefit in clinical trials. I'm not saying the pain isn't real. I'm saying there are ways to address it that won't put your safety at serious risk. The fourth category is one that a lot of patients don't think to question: muscle relaxants. These are often prescribed alongside arthritis treatments because arthritis frequently causes muscle tension and spasms around affected joints. The logic seems reasonable. If the muscle is in spasm, relax the muscle. But the medications used to do that, cyclobenzaprine, sold as Flexeril, carisoprodol, sold as Soma, methocarbamol, baclofen, carry a specific and well-documented set of risks in older adults that make them extremely problematic. The most immediate risk is sedation. These medications cause significant drowsiness. And I want you to think about what drowsiness means when you are 68 or 74 years old, and you get up in the middle of the night to use the bathroom. or you're walking down the stairs in the morning. It means falls. It means accidents. It means potential catastrophe from something as simple as taking a pill before bed. But the sedation risk is not even the main concern. These medications belong to a class called anticholinergic drugs, and anticholinergic side effects in older adults are particularly troubling. We're talking about dry mouth, constipation, urinary retention, which is especially concerning for older men with prostate issues, and, most significantly, cognitive effects, confusion, memory problems, disorientation. In older adults who are already at some risk for cognitive decline, anticholinergic medications can accelerate that decline meaningfully. Cyclobenzaprine, Flexeril, is explicitly listed in the Beers Criteria 2023 as a medication to avoid in adults 65 and older. Not to use with caution, to avoid. The entire class of skeletal muscle relaxants is flagged. The evidence for their effectiveness in older adults with osteoarthritis is weak. The evidence for their harms is strong. That is a very poor trade-off. Safer alternatives include targeted stretching programs, heat therapy. A warm compress or heating pad applied to a stiff joint can do more than people realize. And low-impact movement practices like gentle yoga or Tai Chi, both of which have evidence supporting pain reduction and improved mobility in older adults with arthritis. Physical therapy that specifically addresses muscle tension and joint mechanics can also provide meaningful, lasting improvement. And the fifth category, this one surprises people more than any of the others, I want to talk about supplements and over-the-counter combinations. I hear this from patients regularly. Doctor, I'm only taking natural things, nothing prescription. And I completely understand the appeal. If something comes from a plant, if it's sold without a prescription, if it's been used for generations, it feels safe. I understand that instinct. But natural does not mean harmless. And it especially does not mean harmless when combined with prescription medications that many older adults are already taking. Let me walk you through the most important ones. Willow bark is one of the oldest natural pain relievers known to man. It is where aspirin originally came from, which means that taking willow bark is biochemically very similar to taking aspirin. If you are on a blood thinner, warfarin, clopidogrel, combining it with willow bark can significantly increase your bleeding risk. This is not theoretical. This is chemistry. St. John's wort is widely used for mood support, and many people take it without mentioning it to their doctor. But St. John's wort is a powerful inducer of liver enzymes. That means it speeds up the metabolism of dozens of prescription medications, including warfarin, digoxin, certain cancer medications, cyclosporin, and many others. If you are taking St. John's wort, the effective dose of several of your prescriptions may be significantly lower than your doctor intended. That is dangerous. High-dose calcium supplements are another one I want to address carefully. There is some research associating high-dose calcium supplementation, not dietary calcium, but high-dose supplemental calcium, with increased risk of kidney stones, and in some studies, potential cardiovascular concerns. Food-based calcium remains the preferred source. If you are supplementing, doses above 500 to 600 milligrams at a time are less efficiently absorbed and may pose more risk than benefit. And finally, I want to flag a category that doesn't get enough attention: joint health supplements marketed specifically to arthritis patients. Many of these products are sold over the counter with appealing labels and heavy advertising. But some of them contain hidden NSAIDs or undisclosed active ingredients. The FDA has issued warnings about specific joint supplement products that were found to contain pharmaceutical ingredients not listed on the label. Without FDA pre-market approval for most supplements, there is genuinely limited oversight. What does have some evidence? Glucosamine and chondroitin have mixed but generally modest research support, and their safety profile for most people is acceptable. Omega-3 fatty acids from fish oil at reasonable doses have anti-inflammatory properties and are generally well tolerated. The key message is this: tell your doctor and pharmacist about every single supplement you are taking. Every one. Even the ones that feel too minor to mention. Drug-supplement interactions are real. They can be serious, and they are completely preventable. But only if your care team knows what you are taking. I know that was a lot of information, and I want to make sure we don't leave here without talking about what you should do. Because knowledge without a plan isn't very useful. First, ask your doctor for a medication review. Bring every single medication you take, prescription, over-the-counter, and supplement, in a bag to your next appointment. This is sometimes called a brown bag review. Your doctor or pharmacist can go through all of it and identify any overlaps, interactions, or medications that may no longer be appropriate for your age and health status. Second, ask specifically about the Beers Criteria. You can say those exact words to your doctor. Are any of my current medications on the Beers Criteria list? A good physician will welcome that question. It shows you are an engaged, informed patient. Third, explore non-drug approaches seriously. I say this not to dismiss medication. Medication has its place, but because the evidence for exercise, physical therapy, weight management, and dietary changes in managing arthritis is genuinely strong. These approaches don't just mask symptoms. They can address underlying mechanics. They improve muscle strength, reduce joint load, and improve quality of life in ways that a pill simply cannot replicate. And fourth, consider asking for a referral to a rheumatologist if your arthritis is moderate to severe. Rheumatologists are specialists in arthritis and autoimmune conditions, and they are often more current on the latest treatment options, including biologic medications that have transformed the management of inflammatory arthritis, with profiles that are often safer for older adults than older drug classes. Let me leave you with this. Managing arthritis after 60 is absolutely possible. People do it every day. They live active, engaged, meaningful lives with arthritis. But doing it well means being smart about the tools we use. It means understanding that the body we have today responds differently than it did 20 years ago. And it means being willing to ask the hard questions of the people who are prescribing for us. You are not just a passive recipient of a prescription. You are a partner in your own healthcare. And the fact that you are watching this video, educating yourself, taking your health seriously, that matters more than you know. So to recap what we covered today. Number 1, high-dose oral NSAIDs like ibuprofen and naproxen carry serious risks of GI bleeding, kidney damage, and cardiovascular events in seniors. Number 2, long-term oral corticosteroids like prednisone can cause bone loss, blood sugar problems, and immune suppression. Number 3, opioid pain medications, including tramadol, dramatically increase fall risk and carry serious neurological risks in older adults. Number 4, muscle relaxants like Flexeril are explicitly listed as medications to avoid in adults 65 and older. And number 5, natural supplements are not automatically safe, especially when combined with prescription medications. Please share this video with someone you care about who might need to hear it. And if you have questions, leave them in the comments below. I read them and I do my best to address common questions in future videos. Until next time, take care of yourself. You've earned it.